Let's get started. Good morning. This is Raj Dave from Camp Hill, Pennsylvania in USA, course chairman of C3, and welcome to our inaugural first show of Coffee Cases and Controversies. Today, it's a great honor to have Dr. Giulio Guagliumi from Italy, who really doesn't require any introduction. He's very well known in the field of interventional cardiology. He serves as the director of interventional cardiology unit at Ospedale Papa Giovanni in Bergamo. He's a pioneer in the clinical use of optical coherence tomography and light-based imaging for evaluation of coronary atherosclerosis and stenting. He's authored over 260 peer-reviewed publications in cardiovascular research and clinical trials across all prestigious journals. He was president of the Italian Society of Invasive Cardiology from 2009 to 2011. And he has been a co-chair of the scientific program of interventional cardiology at ESC Congress from 2012 to 2015, and was supposed to be one of our award winners for 2020 edition of C3, which unfortunately due to pandemic didn't occur. It's also my great privilege to have a course co-director of C3 and a very well-known interventionalist in US, Dr. Parag Doshi, who is the chairman of Chicago Cardiology Institute, is very busy interventionalist. He's a great expert in CTO and atherectomy. He's also going to join discussion today of this very, very interesting case. The idea of Coffee Cases and Controversies is to bring to you some clinical pros with the help of showing you some interesting cases. And it's my open invitation to all our viewers that if you have a great case and you want to be part of this show, which is going to occur every month, the next one is going to be on January 16th. My email is rdintervention@yahoo.com. Please send a case to me. We will review it in our board of this show. And if we feel that this case will bring immense educational value to all of you, then we will certainly show you. So without further ado, with that introduction, let me wish you all a safe and happy holidays, as we will now next time see each other in New Year's. I know it's been a tough year for everyone, and I totally understand that we have not been able to see each other, but with the medium of web, I am very pleased to help the situation and get all of us to gather at least by a web medium. So let's pray to the God that the vaccine arrives soon enough, and the effect of pandemic goes down. Everyone, all the physicians, wherever they are, remain safe, and we all have a good holiday. This is a case where imaging really helped. So let me share my screen now so we can start looking at the case. This is my disclosure. I'm a speaker for Abbott Vascular Devices as well as AstraZeneca. I'll be talking about their products in this case. So this is a patient who is an 82-year-old gentleman who actually is an oral surgeon, retired oral surgeon, who has history of diabetes, hypertension, hyperlipidemia. He was admitted at an outlying facility with unstable angina. He had a stress test at that facility which showed inferior wall ischemia. He underwent cardiac catheterization, where only a mild disease of the left coronary system was identified. His ejection fraction was 45%, and he had a severe ostial and a proximal right coronary artery stenosis, which was subthoracally occluded, and the patient was referred to my facility for further treatment. So let me show you this angiogram, and then we're going to pull in our moderators to comment on this angio and see what their opinion is about how should this lesion be treated, and some of the important angiographic features of this complex right coronary artery. So as you can all see, the long, complicated diffuse disease, all degree of calcification, which is fluoroscopically quite easily visible, and disease extends all the way to the ostium. So Parag, you see this type of stuff all the time in your practice. How would you, what are the things that, strike you? You are on a mute, I think.
Got it. Can you hear me? No.
Yep.
Okay. So right away, this is the type of lesion, even whether you are experienced or not experienced, right away you have to recognize that this is highly prone to complication no matter what you do. So my procedure preparation is mentally creating a battle plan, not just so that I can get it open, but I can get it open without complication. And here is why, because it's not just, at least angiographically, it's not just, it is calcium. It looks like that if I were to do intravascular ultrasound, this is going to be either a massive calcification extending both intima and media, or its other possibilities. It's also, there's a chunk of calcium on one side, i.e. eccentric calcium, which can lead to higher chance of vessel perforation. My device of choice in this is rotational atherectomy. Intravascular ultrasound, OCT, those may be good tools. I'm not sure I'll be able to even get the catheter through that. So this will be the procedure where, at least at this time, I would actually use rotational atherectomy. I also would try to limit my atherectomy to the specifically the proximal area, because what I would know that intravascular ultrasound would show calcification throughout the vessel. I would try to sort of control my urge to intervene on a long segment. Most of the times when I do rotational atherectomy, at this time, I modify the plaque and then finish the job with the balloon and stent, and therefore keep a small burr. But in this case, I actually would probably go with an 8 French guide, and I would actually try to get 0.6, 0.7 ratio between the vessel diameter and my rotational burr. So this is where actually I would consider going to 1.75 or 2 of burr. Of course, with all the usual precautions in terms of if the need be the pacemaker, temporary pacemaker, also aminophylline IV. In this kind of cases, I still use it in keeping the patient well hydrated, and in the usual atherectomy precautions such as short passes, no more than 10-15 seconds. Be very, very slow, and then not letting the burr slow down, which can increase the size of particles and cause no reflow. Now, would you like me to keep on going, Rod?
Yes, so I think that, there is a question from the audience, and I'll take that. What type of lesion, or when do you use Diamondback versus rotablation? So I think that, the strategy here, as Parag described, clearly there is a large amount of fluoroscopic calcification. The lesion is very tight. It's to the ostium, so a large guide catheter such as 7 or 8 French is a good idea. Parag feels that we should use a large burr. I do think that, I have a fair amount of experience with both devices. What my concern would be for orbital atherectomy in a situation like this is that this requires a leading edge ascending device rather than a device like a Diamondback, where the leading edge is not cutting surface, and there is also a fair amount of angulation. I would avoid using a Diamondback in a situation like this. I think this is a lesion which calls for a rotofloppy wire and a rotational atherectomy as suggested by Parag. Parag also predicted that the imaging catheter would not go through, which exactly what happened here. You can see that the initial attempt was made to look at the lesion with the IVUS. IVUS did not cross the lesion. So I slightly did this somewhat differently. I decided that I would treat this with a guidance of imaging, and you can see a rotofloppy wire was advanced into the artery with some difficulty. However, ultimately the wire was able to be placed, and a 125 bar was utilized. And then we were able to cross the lesion with an IVUS, and I don't have the proper software to show you the entire IVUS run, but I picked an image that yes, we did do some ablation, but there still was a lot of thick calcium. So let's pull Dr. Guagliumi from Italy in the discussion about the choice of imaging. Here we used an IVUS, but would you have done this? Would you have said, should this be a better assessed by OCT?
Okay, this is a super interesting case. Is an old man. He was a surgeon, so you have a lot of instability, not only clinically but also emotionally, and you have to deal with a very complex lesion where you have severe calcification, some involvement of the ostium, and it was good to try to get through this lesion by using imaging. And one of the common points that we needed to address with imaging is that we have beautiful images with us, but we needed to confront with a very complex lesion. And sometimes the catheter fail in crossing. So at this point, it was clear you attempt, you was unable. Then based upon the calcification, you decide to go with a rotational atherectomy. And so I think it's very reasonable. You needed to work with the technology you are familiar with, and that is very important. And then you needed to confront with this type of complexity. So very reasonable to try to get before to be informed about the amount of the calcification, the type of calcification. There was a question discussing about a shockwave versus rotational atherectomy versus the diamond back. And of course, you needed to see, but when you have a lot of calcification, can be challenging. So now you had your imaging. So I think that we wanted to listen in you going ahead with the story.
Yeah, so I think that you can see that there was still a lot of thick calcium. A proper antiplatelet therapy was given, as Parag accurately suggested that there is a potential for no reflow. So we wanted to make sure that this patient's antiplatelet therapy was well managed. This patient was given Cangrelor. I know Cangrelor may not be available outside of the United States, but it's an ultra short acting IV antiplatelet agent that we really liked using because of its fast onset and a fast offset. And ticagrelor was administered to the patient, and a larger bar of 1.5 millimeter size was utilized after a 1.25. And then the entire diffuse disease was treated with two drug-eluting, everolimus-eluting stents. And this is the final result. And the patient did very, very well for overnight hospitalization. He was then discharged on a dual antiplatelet therapy. Because of the cost reason, the patient was discharged on clopidogrel and aspirin rather than ticagrelor. And however, he showed up 2 weeks later again to an outlying facility with a recurrent episode of angina. He was admitted there. He ruled out for myocardial infarction by cardiac enzymes. I trust that he was compliant with a dual antiplatelet therapy, as he stated. So he underwent a repeat nuclear stress test. And you can see that it showed a large amount of inferior wall ischemia. Hence, he was sent back to us due to this finding and his ongoing anginal episodes. And this is the repeat angiogram with the image that you are seeing. The vessel is not completely occluded, but you can now see that there is an eccentric, complex appearing lesion of some type, and it was unclear to us what it was on a repeat angiogram. So let's pull our moderators back again and see, Parag, if you see this 2 weeks later, the stents, this is not, I don't know how to figure it out, what this is. What would you do with this situation? You are on mute, Parag.
This will definitely give me a bit of stomachache because these are tough lesions to accept. So this is one of the two possibilities. The one possibility, it is a clot that is either formed locally or proximally and then sort of set on the cut. And the other possibility that this is a protruding clot or thrombus from the area where you did the atherectomy. Here, I think OCT and or IVUS would be invaluable to characterize it. And I actually, in this case specifically, before I do anything, I would very nicely aspirate, do aspiration thrombectomy after characterizing, assuming that this is a clot. You can actually make an argument that this is one of the few lesions where a coronary angiojet thrombectomy may be appropriate. And then using IVUS or OCT, depending on your expertise, obviously, I don't have much experience with OCT, so using IVUS, look at the stent morphology, whether the stent was expanded appropriately, get the re-expansion of the stent while making sure that in these supercalcified lesions, try to overexpand the stent, and especially if it's an eccentric calcium, you have a more chance of perforation. So getting a good balance and making sure that you have a good CS, a good surface area of the stent, that would be the end game.
So here, I agree with all of those comments. All of those are great ideas, given that there was a flow here in the right coronary artery, I felt that this was an opportunity for us to do an OCT to really identify what the etiology of this stenosis is, as this was unclear to me that why, whether this is a plaque protrusion, whether this is a thrombus, under expansion, what have you. So I decided that, before I do anything to this lesion, I should do an OCT run. So this is the OCT run, which was done. And now we'll ask our world expert in OCT to show us the OCT run and help us interpret. So I'm gonna stop sharing my screen now and have Dr. Guagliumi share his screen so we can see the OCT run.
Can you see my...
Perfect, yes, we can see great.
So, Roger, very interesting at this point. So the first is to leave this sequence running. Is exactly what we might see in life. So you have this longitudinal view where you can see there was quite a longer segment of the catheter. And then this is the first piece and the first segment of the right coronary artery investigated, the ostial lesion and then the remaining. So there are multiple challenges point. This is the what we call apposition bar, that is telling you if your stent is apposed or not. White means fully opposed, red means that you have some malapposition. But this software is working on the perfectly clean view. So one first concept is it's extremely important while you see the pullback with some blood contamination to try to have an optimal OCT obtained. That is only a matter of tricks and proper engagement of the guiding catheter. So here you can see the pullback is going through the mid and proximal segment toward the ostium. Let's stop now and let's go to see section one by one. So we are starting from the mid portion of the right coronary artery. Very nice. You can see clearly all of the struts. Each strut has the shadowing. Here you can see clearly around with a very beautiful circular geometry. And then we are moving back. There is not too much blood. Then the blood is coming from 4 to 6. And you can see that your algorithm that is telling you if the struts are opposed or not is becoming crazy because he has blood and he is confused. So very important to try to optimize the quality of the OCT since the beginning. Then you can see again, and then this is a transition point. This transition point where you can still recognize the struts was not something like a fracture or a miss point. You can clearly recognize the struts at this point from 7, 9, 10. And then from the opposite side, you cannot see any struts. And this is a part of the deal when you have some plaque protrusion or thrombus. How we can say that this is something inside? You can see when you have tissue inside, you have a dumping of the struts. You can see clearly the struts at noon, 11, and on the left side, while you cannot see anything on the right side. And also in this case, the algorithm that is reconstructed in 3D, the profile is becoming crazy. So very important to have a perfect interpretation. Here you can see this tissue that is a thrombus is dumping the struts. They are located around the circumference. And we can see also some more clear evidence of the thrombotic apposition. You can see here that the thrombus is touching some struts. Here you can see clearly these struts and you have this small massive protrusion. So the filling defect was essentially a thrombus, but there was also some clear under expansion on the middle portion where the thrombus was forming. When mechanical cause adjunct to some flow turbulence, disturbance, and thrombus deposition.
Parag, any comments?
I actually have a question for Dr. Göran. So, I don't have experience with the OCT. How do you differentiate on the OCT whether this is a protruding thrombus versus a plaque protrusion, because our approach may be a little different?
Absolutely. So that is a good point. So the first point I would like to address is the most important point where you can use imaging is during the procedure, and especially baseline to define your strategy. If you cannot cross because it's a too tight the lesion, you open up the channel by using rotational atherectomy, and then you go to use imaging, because the imaging is telling you if there is a calcium, especially OCT, which type of mechanical opening you have obtained. If you have a fracture, they are very important for expanding your stent. So don't miss this priority time. The priority time is during the implantation, and then you check at the end of implantation. Here, when you have the thrombus forming, you have some protruding rounding shape and masses attached to the struts, plus half of the circumference that was damping the signal. And so sometimes, especially if you have a larger lipid protrusion, it's not easy to be differentiated. But in this case, I would say that the vast majority of the information are converging toward mechanical under expansion and thrombus formation.
No, that's those are great comments. So Parag, I did what you were originally talking about, and I did do a thrombectomy with an aspiration catheter. Can you see my screen now?
Yes.
Yeah, so we did do that. So etiology of coronary stent thrombosis, just as a reminder, platelet inhibition if inadequate, and we don't know in this particular case, we do not do point of care platelet testing in our lab. However, I'm assuming that we have a better etiology for this thrombus formation, stent under expansion, as Dr. Guagliumi just very eloquently explained, geographic miss where we implant stents and we miss important part of disease at the edges of the stent, heavy calcification, stent length, and acute coronary syndrome, which are all known factors which increases the risk of stent thrombosis, even though with the current generation of drugs and our implant techniques, the rate is pretty low. So after thrombectomy, a decision was made to implant a second stent, which was a lot larger device than the first time. First time the stent implanted was the 3.5. Now this is a 4 millimeter everolimus stent was implanted. And this is the second time after stent implantation and OCT examination. So let me stop sharing the screen and have Dr. Guagliumi make comments on the approach, and then we'll show us the second OCT run.
Can you see my screen?
Yes, we do see perfect.
Okay, let's try to start having some idea, the longitudinal view here, and then some cross section, and then this automatic lumen detection board. We wanted to have this pullback running. You can see the distal part round in shape, the struts with the shadowing. Then there is a malposition. We will be back soon, totally undetected by angio. So the lumen is smooth. There are no protruding masses at this point. Some blood, again, disturbing the algorithm. Very important to try to avoid. But now is very widely open, very circular in shape, and there are no any more protruding masses. If you have a protruding tissue, that could be difficult to be fixed this way. And then we are going toward the catheter, and we will spend some additional time on that. So let's go back to have some idea about the different section. So this is the distal, round in shape, wide lumen. Then we are going here. And you can see the struts with the shadowing, but the struts are not fully opposed from noon up to 5. There's a malposition detected by the automatic lumen detection border and the stent position in red. And so if you are moving back and forth, you can see that the struts are now touching the vessel. And then here, the struts are protruding into the vessel with a wide space in between. That's basically must be fixed if you're using imaging. Then we are going back, you can see clean, circular. And I was saying, we wanted to spend a little bit of time at the ostium and entrance. This is round in shape, large lumen. Here we are going to the ostium. When we are approaching the ostium, you can see that your stent is much smaller. And so the difficulty in this lesion that are starting from the ostium is to be sure that you are including the ostium and you are optimizing the ostium. So not to be critical with Parag, but this is what the images are teaching us in this case.
That's great comments. So just as you saw that there was an under expansion and malposition This entire area was then post-dilated with a long inflation using a 4.5 millimeter non-compliant balloon. So now Dr. Olivecrona has joined us from Sweden, and he commented earlier about that would we have considered lithoplasty. So the lithoplasty in the United States is not commercially available right now. The Disrupt 3 study was just completed and it's awaiting approval, but I believe that the lithoplasty is available in Europe. My concern would have been though, however, knowing the lithoplasty balloon in periphery, that whether a lithoplasty device would actually go into this tight stenosis without rotational atherectomy. Göran, what's your thoughts? And would you have done lithoplasty after the stent implantation?
Well, I think that using shockwave lithoplasty would have been an option, but I would have started with 1.25 burr, just like was performed in the case. But there's also a development. It was a little eccentric how the stenosis and the calcium was located. And in those areas, those cases, it might be a good idea to start with a rotablator, and then after that continue with lithoplasty, so it becomes a rota shockwave case essentially. And especially in these osteal lesions, this is something that we do not so infrequently.
Now, in terms of Göran, the rotational atherectomy size, Parag and I were discussing about, starting with a small burr and then stepping up to a larger burr. What's your thoughts?
I think that I would have done, if you're using only rotablator, I would have started also with a 1.25 burr. But there's some controversy. There's one group belonging more to start with a 1.5 burr, but on the other hand, there are a lot of people that will almost start with a 1.25 burr. I would personally start with a 1.25, and then I would probably have gone up if lithoplasty wasn't an option, or if I couldn't get a shockwave balloon in, and gone with a 1.5. And perhaps at that point, it would have been good to see if you can see any cracks in the calcium. That could have, could you have started with balloons from that point on, or should you even debulk even further?
Yeah. So in Japan, I have had opportunity to work with Dr. Akasaka and Dr. Shite with calcification and OCT, and they use an algorithm where they would look at the thickness of the calcium and the lumen to decide on the size of the rotational atherectomy bar. Giulio, do you use OCT guidance to decide on the size of the device after you make a first channel?
Okay, absolutely yes. I'm fully in agreement with Dr. Olivecrona. So I will do the same. So open up the channel, and then when you have established the possibility to use imaging, the catheter was already open, you check, and then you decide based upon the lumen and the calcification if you needed to escalate in terms of size of the burr, or if you needed to switch it to another technology. So I think the message is still very, very important to use imaging to guide your strategy at the time of implantation, and you will reduce the risk to have this patient coming back with trouble.
Giulio, in terms of the minimal stent diameter and minimal stent area, are there any specific numbers and the parameters that you look at in this type of cases where you would say, okay, this is an acceptable result?
So expansion is very important. In the right coronary artery, you don't have too many branches. So the tapering is not normal because the size stay the same along the vast majority of the vessel until at least the distal part. And then you take the distal and the proximal reference. So what is challenging here is that the ostium was involved. So you will never know about the proximal reference. You will start to be based upon the distal reference if you don't have a tapering. and then you try to get a minimum of 4.5 millimeter square area without a protrusion, and then to have an optimal expansion. You divide, likewise we are doing in Illumin 4, that is not very far, to end up with a full enrollment of 2,500 patients with a complex lesion, to have an optimal expansion. That could be 90 or more than 80, but that is the way we are guiding the procedure.
Parag, you were going to comment on some of the audience questions.
So this is a phenomenal representation. I actually got to learn a lot from OCT, and I think I'll have to go in the National Hospital get OCT. Procedural question came up that what is the guide wire choice and what is the guiding catheter, and some practical pointers. So in this near ostial complicated lesions, one of the issues that you struggle with, the how do you position the stent very well. So specifically, I avoid supportive guides such as implants because they tend to dip seat. So I stay with a JR4 simple guide. Even though temptation is to finish off the case with the rotafloppy wire, I actually, for the near ostial lesions after my travels and difficulties, I actually switch it to a very heavily supportive wire like Miracle wire. And the idea is simply that when I disengage the guide to position the stent, if I have a floppy wire, the guide just jumps on and then you lose the wire. So I almost always, for the near ostial lesions, use a simple guide with a heavily supportive wire, typically Miracle 3 to 12, any of them, so that when I disengage the guide, the equipment does not jump off and I can position my guide very carefully. If this patient came back and then I already have a stent which is under expanded with calcium, then laser atherectomy is a good choice to fracture the calcium after the stent is in place, because then the rotablator may or may not do a good job, or you can fracture the stent. And those would be some practical pointers in this case.
There is another audience member who's commenting regarding that how we can avoid this. Is post-PCI imaging should be mandatory, or maybe stronger stents such as Megatron or renal stents. Any thoughts, Giulio, about mandatory use of imaging? I personally would absolutely do it myself. I think Parag would, at least Iversit, he doesn't have OCT, but just about to get one. And Giulio, you're obviously, I would rely on OCT for a situation. Now, tell us a little bit about, if there are any tips and tricks on how to use OCT for these ostial lesions, and
Okay,
you get a good imaging.
Okay, absolutely. When you have a purely ostial lesion, so my personal recommendation is go to IVUS. Because in any case, you need to have a minimal engagement of the catheter. And it does not mean that you are becoming occlusive with your catheter. You need to be very accurate and then try to get some idea. I think that it's about the plan is very important to try to understand the substrates you are dealing with in complex lesion, especially when you have a lot of severe calcification. Very, very important to understand how much is, how long is, where it is, and then decide, guide your procedure, because you're already pay for the catheter. Guide your procedure after the intervention is very important to realize if you have some part of your procedure that can be optimized. So I think that that is the recommendation, under expansion, and make measurements. Make measurement is extremely important, not just one single cross-section, but try to understand if your stent is expanded or not. It doesn't matter by using IVUS or OCT. OCT in this case is quicker and easy to make this calculation, but IVUS, you must do the same.
Those are great comments, a tremendous learning, a lot of important points here being made. Göran, the last issue is about more stent stronger stents, for example. You know, there's a lot of comments about strong stents here from the audience. That should we use something thicker, like a renal stent?
Yeah, this is something that I've heard about it before, but in the last 2 years I've started using this in cases like this, that you put your first stent in, you've done your initial work with the rotoblade or whatever, you get a nice expansion of the balloons. But if you look on stent boost or something like that, you often clearly see that there's recoil immediately after stenting. And how do you deal with that? One way is to go to another normal coronary stent, and sometimes that solves the issue. But we've started also using renal stents, which I know, or what I know, the smallest one is 4.5 in diameters. And if you have a small vessel, then you can implant even a large stent, but with low atmosphere, and then go back with an NC balloon that is more sized to the vessel and fully expanded. And I think one of the things is that you need to have first implanted a drug-eluting stent. And after that, you can implant the renal stent, which is usually bare metal. And these are then 120 microns and upwards of thickness. And you get, this is something to counter recoil with. And we've done this in a small number of cases, but successfully. And we've followed them up with follow-up angiography, and it's looked well.
Now, Dimitri, Nikas from Greece has joined us, another scientific advisory members of C3. Happy holidays to you. Dimitri, you wanted to make a comment about post OCT. You are on mute.
Thank you very much. Can you hear me now?
Yes, we can hear you. We can see you. Great.
Perfect. This is something I usually have a problem when I do post OCT staining procedure, and this is something I would like to have Professor Guagliumi advise. The real problem when we do OCT after we put a stent in an osteal lesion, especially when this regards the left main, is that we can easily visualize the stent very well with OCT, because we cannot flash away the contrast in a good position, because the catheter will not engage well the ostial of the vessel, so we cannot flash out the contrast very well. So in this case, at least to my practice, I usually use a guide liner and put it in the stent, and then you can visualize the stent nicely over the guide liner. However, this is not always the case. So I would like to have the Professor Guagliumi advise what you can do in a case like this. And since we have osteal lesion and we treat more and more left mains, at least in my center, we have really a problem to visualize well the position of the stent, especially at the osteal side.
Okay, I think that you have a tough interventionalist. So I'm sure that you can do easily. So one of the most important is the story of the contrast. You are losing a lot of contrast, the images are not good in quality. It's a matter of sensitivity. And so you needed to dedicate a significant time in trying to stay in the right position when you try to engage the ostium, also in terms of a catheter selection, without going too much into, but not stay out. And then the second point is always, before running the pullback, do a puff of 3 cc, and you can immediately see the quality of your images. And if the images is clean and good and you don't have blood, it means that you can run your pullback. And you are not risky to have a contrast lost and then the need to rerun the pullback for a second time. So it's not only a matter of pushing and pulling, sometimes it's a matter of to be sensitive with your hands and to try to orient the catheter to sit in properly at the ostium. Of course, you cannot see the last 1 or 2 millimeters of the ostium. So if you have a short left main with the ostial involvement, this is a recommendation we are making in favor of IVUS. But if you have not this kind of aspect, you can also run OCT at a very high level.
Well, great. Those are all great comments. We just crossed over 1,200 viewers all across the world. I want to send my regards to everyone in Asian countries who has joined us in the evening. Happy holidays to all of you. Great case. A lot of discussion. We will see everybody again on the 16th of January to summarize the case. This was the case of a complex calcified coronary lesion and how we can optimize the result to prevent complications. This patient, just to report you all, has done extremely well. He has become completely asymptomatic and has been a couple times in follow-up with me and is doing very, very well now. So that's good news. But we all come across this type of complex lesion. We're going to have a discussion on another great technology on January 16th for the second episode of Coffee Cases and Controversies. I want to specifically thank Dr. Giulio Guagliumi, who took time out of his very, very busy schedule in Italy to be with us today to explain and comment on OCT. We learned a lot. Dr. Parag Doshi from Chicago, who's on call today and still was able to be part of it. Thanks, Parag. Dr. Olivecrona from Lund, Sweden, was also very kind in taking the time on Saturday to be with us, and Dr. Dimitrios Nikas in Greece. Thanks, Dimitri, for being part of it. You all have a wonderful rest of the day. Happy holidays to everyone, and we look forward to seeing you again in the New Year's, 16th January, 10 a.m. again for Coffee Cases and Controversies.
Thank you very much.
Thank you.
Thank
all.
you. Bye-bye.